All, on behalf of IRIA Kerala, I welcome all for the PJ case presentation series on gastrointestinal radiology in association with JournoMed. In this context, I welcome Dr. Gomati Subramaniam, President IRIA Kerala, Dr. Rijo Matthew, Secretary IRIA Kerala, and Dr. Ramesh Shanai, Program Convener. And today, our faculty is Dr. Anuj Takara, is a Senior Consultant, Diagnostic and Interventional Radiologist in Seva Bharati Diagnostics, Ashok Vihar, Delhi, and also in Dr. Takaral's Center for Ultrasound. I welcome you, Dr. Anuj. And also I welcome the moderator, Dr. Anish, he is Associate Professor in Malabar Medical College, Calicut.
Thank you.
Once again, I welcome all of you for this wonderful session. Now over to Gomati Madam for the opening remarks.
Thank you, Dr. Venu, our academic chairman, who's always with us to conduct the academic sessions, and Dr. Ramesh Shanai, who's our program coordinator, always helping us. This month, I think we are in the last week of gastrointestinal series. We have a residence for gastrointestinal series, who was the case presented by Dr. Anuj. We are having a wonderful time with the residents, and lot of cases residents are seeing, and all are benefited by this. So I'm happy that the gastrointestinal system went on very well this month. And today, Dr. Anuj has given the cases. With the help of moderator, Dr. Anish, we will be conducting the program today. So I take this opportunity to thank from behalf of Kerala IRA. Thank you and welcome all of you. Over to you, Anish.
Yeah, it's my pleasure to introduce to you Dr. Anuj Takara, DNB and PDCC Gastro Radiology. He has done a senior residency in multiple hospitals in Delhi, Lady Harding Hospital, and ESI Hospital and ESA Hospital in Delhi, and also worked as a senior resident in SCPJ Lucknow. Thereafter, he was working as consultant in Max Hospitals, Delhi, where he was very much interested in academics. He was involved in academics. He was a thesis guide for PGs at the DNB thesis guide. And thereafter, in last year, he has started his own center, Dr. Takara Center for Ultrasound and Intervention Radiology. Currently, is managing his center and also working in Seva Bharati Diagnostic Center and Ishan Hospital and another diagnostic center. So I welcome Dr. Anuj once again to Kerala IRIA and today's session. Also with us are two PGs from Calicut Medical College, Dr. Narmin and Dr. Girish. Each will be presenting one cases on GI radiology. Over to you, Dr. Anuj.
Well, Anish, thanks for the kind introduction. I remember the days we used to spend together when we were senior residents in the CBJ. Yeah. With all those active gastro meets every week, he used to be part of.
Yes.
And well, we can start with the cases.
Yeah.
The first.
Yes, sure.
And we'll start.
Dr. Namin, you can start.
Yes, madam.
Yeah.
I've been given 68-year-old ladies axial sections of CT, abdomen and pelvis. This is plain sections of abdomen and pelvis. There appears to be a redundant colon, a redundant sigmoid colon with a short segment circumferential wall thickening with an exophytic component with significant pericolic fat stranding and features of inflammation. And multiple rounded pericolic lymph nodes also. There is no evidence of upstream bowel dilatation. There is no evidence of pneumoperitoneum.
How do you say that there is no pneumoperitoneum?
There is no evidence of air foci outside the.
What do you say on this image?
That's difficult, sir.
So you should not give a passing statement.
Okay, sir.
You have the option. You can show us how will you say whether there is air or not. You have the option
Yes, sir. I can widen my window.
to do that. In fact, this is a very good opportunity. You are getting the whole data set. Otherwise, in the exam, you will just get the fibs.
Yes, sir. Sir, there is no evidence of air foci outside the confines of bowel wall. There is no ascites.
Okay.
The rest of the contrast enhanced study.
Well, on non-contrast, you have other findings also. You don't leave the other findings. There are other findings also from top to bottom if you scroll down. They may be relevant.
There is mild prominence of right renal pelvis and right ureter. And there is this exophytic component near the sigmoid colon appears to have lost fat plane with adjacent cecum and adjacent ileal loops. And the bladder wall is also mildly thickened, and there is thickening of peritoneum adjacent to the bladder wall.
Okay.
Anything
else in the plain CT of the as per the unit bladder is concerned? Do you see anything else in the plain CT? Subtle finding, but yes. What is this?
Vesicle calculus.
How can that be a vesicle calculus? That is non-dependent. Ideally, the vesicle calculus has to be dependent, non-dependent. This is. We'll take it forward. We'll see it in the next series. Anything in the upper abdomen? Very cursory finding, but important.
So mild splenomegaly.
That was clear. You poked the finding and you just passed it off. You did not speak about it. It is a small finding, but it is still to be spoken. It is not to be missed. You can't skip it totally. See,
There is
what is this?
cholelithiasis.
Yeah, so you have to speak about it at least.
Okay, there's a radiodens calculus within near the neck of gallbladder.
Yeah, you have to speak about it. No, it is a finding. Everything will carry marks. If you are, if somebody is counting your findings, then they will carry marks.
Okay,
This you have missed. This is, though it is a small finding, but it has to be spoken. Sometimes it may be carrying some relevance somewhere in the diagnosis. You can't just extrapolate it right now. So
Okay,
go ahead.
With the arterial, with the contrast.
Yeah.
There is enhancing wall thickening, symmetric concentric wall thickening involving sigmoid colon as already seen. Other than that,
In this patient, what is the use of arterial phase as far as what is the likely relevance? You might find a certain finding which might be of critical, which might be of importance on the arterial phase also.
if there was it's a case of frank bleeding from rectum, in that case, to identify an arterial source.
Yes, definitely. So we can even say that there is no frank arterial blush that can be seen.
Yes,
The
sir.
focal blush is not, no focal blush is seen, so that is carrying weight in itself.
Okay, sir.
That has to be spoken, or at
Okay.
least you have to keep it in mind. The
So-
examiner might poke you, and it might be there also actually.
Okay, sir.
Okay, go ahead.
In the portal venous phase, the solid organs, including there is no focal lesions except for a tiny cyst in the segment 8 of liver. Other than that, I do not find anything positive.
Okay. What else?
And in venous phase, there is the circumferential wall thickening in sigmoid with the exophytic component shows some areas of non-enhancing areas. Sorry? Sorry, sir?
Yeah, go ahead. Bias was
there is-
breaking actually.
Okay, in the sigmoid column, there is a short segment concentric and wall thickening with some areas showing non-enhancing areas within. There is significant pericolic fat standing, multiple enhancing and few non-enhancing lymph nodes. And the lesion shows contiguous extension into cecum and adjacent ileal loops. So also in cases distal ureter, right distal ureter with upstream prominence of ureter and mild prominence of renal pelvis. The rest of the sigmoid colon appears unremarkable, including rectum. There is an adjacent wall thickening involving bladder.
Yeah, now look at the bladder again. Now look at the bladder again.
Near the dome of the bladder, there is a polypoid projection,
Yes.
which appears to be
There is a nodular
enhancing.
polypoidal thickening actually, which is bulging into the bladder lumen.
Yes, sir.
So this is definitely not a calculus.
Yes, sir.
For sure, that is there. It is not a calculus. What else about the rest of the bladder?
Rest of the bladder, there is my wall thickening and
Not mild. It is significant wall thickening actually.
yes, sir.
The right lateral wall
Is significantly
asymmetric
thickened.
thickening. It
Yes.
is definite enhancing asymmetric wall thickening, moving the right lateral wall, the posterior wall, but also the dome region. It is contiguous. All sheet-like thickening is there.
Yes, sir. Yes, sir.
That is having that endoluminal polypoidal component also into the
Yes, sir.
bladder.
Okay, sir.
So that is all that has to be spoken. Is not to be missed.
Okay.
And with regards to how will you measure the length of the lesion? Will you tell the length of the lesion or you will skip it? Here you have
Sure.
here you
In
have the means to measure the length, so you should tell the length ideally. Give a vague
Okay.
idea at least, because you have
approximately 8
because it is
centimeter.
yes, because it is of relevance to the surgeon.
Okay, sir.
So you should tell the length of the lesion.
Okay.
That is relevant.
Approximately 7 centimeters, 6 to 7 centimeter.
Which plane are you measuring?
Axial plane.
Length. The craniocaudal extent. Yes. Length will be in the craniocaudal extent.
That is approximately 6 centimeter.
6 to 7 centimeters. So you should mention the length of the lesion also.
Okay, sir.
That is of relevance. Okay. What else? So go ahead.
So the 68-year-old female patient, CT section showing short segment, concentric wall thickening involving sigmoid colon with an exophytic component which has multiple non-enhancing areas within, and adjacent mesentery and pericolic area shows significant fat stranding, multiple pericolic lymph nodes, and the lesion appears to have lost fat plane with cecum and ileal lobe, and is also encasing right distal ureter with mild upstream dilatation of ureter, and there is a thickening of adjacent peritoneal layer and also posterior wall of bladder. So my first impression would be a CS, carcinoma sigmoid, and with a differential of chronic mass forming diverticulate, complicated diverticulosis.
What else can that be?
Could be a contained could be a
You mentioned something about the no upstream dilatation.
yes, sir.
How does it carry any weight?
In cases of lymphoma of bowel,
Yes.
it usually does not cause us obstruction. Will be significant wall thickening without upstream obstruction.
So that is there in this case also actually. And
Yes, sir.
what else is there which could possibly point it to be a lymphoma? I'm not saying it is a lymphoma, but here we are not to give a final diagnosis. That is for the histopathology, but we are to look at all the possibilities with a wide perspective. What else can be there? Why do you think it can be a lymphoma besides the
adjacent desmoplastic leg reaction?
What else?
Multiple lymph nodes rounded, enhancing lymph nodes.
What else?
What else? Splenomegaly.
No. About the mass itself. Concentrate on the mass itself first.
The exophytic component.
Yes. But the thing about the exophytic component which negates possibility of a lymphoma, reduces the possibilities that the exophytic component has somewhat those
non-enhanced, heterogeneous.
areas. So they are necrotic. A lymphoma pre-therapy usually will not be necrotic.
Yes, sir.
But this is all necrotic, looking like sloughed off. So
yes, sir.
That goes still in favor of carcinoma.
Yes, sir.
Lymphoma will be more solid.
Yes, sir.
Definitely more solid. Acha, one thing about the technique. Is there any small this thing? When once the technician has done the CT, what small mistake has the technician done? from the plane to the contrast throughout the study. And one more cursory finding that we have missed in the uppermost part of the abdomen.
So there's a mild wall thickening in stomach involving fundal of stomach.
What else about the stomach? What could he have done better on the table itself that he has not done?
Could have distended the stomach.
Yes. They should have ideally given a table dose so that this gastric wall, diffuse gastric wall thickening, which might be spurious, might be actual, you will be able
Yes,
to
sir.
establish it better if you had given a table dose. Though it
Yes, sir.
does still look like there is significant wall thickening, but a table dose would have definitely allayed all the doubts as to
Okay, sir.
the gastric wall thickening. There is one more finding. There is one more finding with regards to the stomach.
Mild small hiatus.
Yes, so that has to be spoken as well. There is a hiatus here.
Okay, sir.
And is your discussion of the case complete? You have not seen a few important findings. You have the data set. Why don't you play around with the data set? Why don't you show us that you know how to look at an oncology case properly? Is that all you will do if you have a data set in any case for that matter, not just a cancer case? Will you not look at other things?
Like bones.
Yes, so show us. This is not how you will show us the bones. In future, you might actually get to have long cases on workstations, so you will then have to show the examiner that you know that
Okay,
things
sir.
are to be seen in this way.
Okay. The bone window. There is no definite lytic or sclerotic lesion other than for the mild osteopenia. I don't have any positive findings.
What is this? What is this? The lower dorsal vertebral body. What is this? Even this has to be spoken of.
Okay, that is a small snout.
Yes. It has to be spoken of, at least.
Okay, sir.
What else? What else will you see?
There is no evidence to suggest a bone metastasis.
What else will you show us?
The ribs,
Bone
pelvic.
metastasis. If there is no bone metastasis, we are done.
Pelvic iliac bones.
Are we done? Even just with the bone metastasis not being there, are we done?
Then in the lung fields, if lung fields are available.
So you need to show that also, na, that
Okay,
lungs
sir.
are fine.
Yes, sir.
That is part of staging, because many times with such large masses, we do tend to find one lung nodule or two, and that changes the entire staging. The liver may be normal, but if there are suspicious lung nodules, then basically your treatment totally changes.
Yes, sir.
So that has to be spoken of.
Okay.
You can't leave it.
Okay, sir.
You simply can't leave it. You have to speak about that as well. So make it a habit that you are seeing this each and every day. Only then you will be able to basically avoid missing these things on a day-to-day basis. Otherwise, if you do it one-off, not routinely, you will forget it. In the exam, you will basically tell what you are doing on a routine basis.
Okay, sir.
Do we have time for more questions, or we take questions in the after the second case? Anish,
Anuj, I think time is there. You can ask questions now,
okay.
or if you want, you can ask at the end also.
We can
Time
take
is there.
take it after the second case. Let both
Yeah,
the
yeah.
cases go at least.
Yes, yes. Okay.
Then we'll come back to the this case and okay.
Good evening, sir. I am presenting a non-contrast CT axial CT sections of Ishtiaq Ahmad patient. Plain axial non-contrast CT sections of thorax and abdomen
Yeah.
showing subcentimetric calcified mediastinal lymph nodes and left hilar lymph nodes. Well-defined fluid density lesion noted involving the segment 4A of liver.
Okay.
Bilateral kidneys appears significantly reduced in size with endowed cortex and cortical cysts within the lesions within the kidneys.
Okay.
Stomach appears adequately distended with hyperdense content within,
Why will you say hyperdense content? This is contrast.
contrast within. Circumferential asymmetrical soft tissue density wall thickening noted involving distal body of stomach extending to antropyloric region with endoluminal polypoidal projections.
Yes.
The lesion appears homogeneous in plain CT.
Not say lesion. You will say the
Wall thickening.
wall thickening, area of wall thickening.
Yes, sir. Wall thickening appears homogeneous in plain CT. Cardia and GE junction appears to be spared from the lesion.
Okay.
Duodenum appears to be spared from the lesion. Multiple subcentimetric perigastric lymph nodes noted.
Are they just perigastric lymph nodes, or there are more lymph nodes also?
Dysentery
Yeah,
also.
measure this one. Measure this one. Is this sub-centimeter? Measure it. Measure
It's
it.
enlarged, sir.
It is enlarged. So you should not say sub-centimeter
Yes,
because your words carry weight.
Yes, sir.
Measure the lymph node for me.
Yes.
No, there is another lymph node. There is another lymph node. Just scroll down. Yeah, just scroll down, scroll down, scroll down. This one, this one, this one, this one. Yeah, this must be around a centimeter. Yes. What else?
No significant perigastric fat stranding or perilesional fat stranding. The lesion noted closely abutting the body of pancreas with maintained fat planes.
Okay.
The lesion appears noted closely abutting the inferior surface of left lobe of liver with no obvious disruption of fat planes.
Okay.
A uniform shaped soft tissue density with central hypodensity resembling that of kidney noted in right iliac fossa with few hyperdense material in the suprapubic region in the anterior abdominal wall, likely representing post-surgical suture materials, and the structure or uniform structures in structure in right iliac fossa representing transplant kidney.
Yeah. So,
Minimal ascites noted.
okay. Is there anything that Acha, you've spoken about the liver, na?
Yes, sir.
You've spoken about the liver also, na? Yes, you've spoken about this.
Yes, sir.
Yes, you have spoken about. What else? What else is there? Any other relevant finding? Acha, what are these kidneys? What
Sir.
these two kidneys that you can see? What are these?
They appears to be contracted kidneys with no hydroelectronephrosis.
What is the difference between these kidneys and the one in the pelvis?
These kidneys are reduced in size with cortical thinning. This one is cortex is well maintained. It appears to be larger for the size, larger in size.
Is there any difference in nomenclature between these two?
Transplant kidneys, this one.
Versus what are those? What will you call them?
Native kidneys.
Yeah, so you have to say that the both native kidneys are shrunken
Yes, sir.
and markedly reduced in volume.
Yes, sir.
That has to be spoken.
Yes, sir.
What else?
Spleen appears normal.
Yeah.
Rest of the bowel loops appears normal.
And that's it. In any other area of bowel that you just need to, since you can see it well, on the last section, go down. Yes, patient is having pain abdomen. So, is there anything else that you will specifically point out on a CT?
Sir.
Patient is having pain abdomen. Is there anything else that you will look for on the CT? Since you have a CT, you are able to see the bowel well. Patient is having pain abdomen, pain lower abdomen, for example.
Colitis.
Well, okay, colon is okay. Colon is fecal loaded. It is not. Colon is fecal loaded. What else?
Appendix.
Appendix. Appendix is also when seen. How do I say that this appendix is normal or it is inflamed?
It is filled with air and contrast and normal in caliber. No periappendiceal fat standing or lymph nodes.
So that means it is a normal appendix. What else? So, what do you think of the? How would this patient have presented? For example, I don't give you the history. What is the history that you expect this patient to have?
Like GRD symptoms, early satiety,
Yeah.
loss of weight.
Yeah. What else?
Epigastric pain.
Yeah. And how will you investigate this further?
Contrast is required.
Well, if he is already dehydrated, for maybe, and then what? Will you look at something? And will you try to skip something?
Sir.
If he is dehydrated, for example, what will you do? What will you look at, and what will you try to avoid?
EGFR.
Yeah. If so, what will you do with the EGFR? Actually, you are deciding to give contrast or no contrast. Preferably, if he is dehydrated, it's quite likely that the GFR will be low, the creatinine will be, KFT will be decreased.
Yes,
in that case, what option do you have? What other option do you have?
Hydrate with an anesthetic system.
That is okay. What other imaging modality can help you actually? Huh?
MRI.
Yes, MR. What specifically on MRI can give you good amount of information? What?
Diffusion weighted imaging.
Yes. So what are you thinking of as the diagnosis? This patient
As
is also
long-
running fever. Now I tell you the patient is also running high grade fever.
Yes, sir. In view of transplant kidney and long segment circumferential homogeneous wall thickening involving stomach, I would like to think of first diagnosis as a lymphoma post-transplant, post-traumatic lymphoproliferative disorder first.
Post transplant, not post traumatic.
Post-transplant lymphoproliferative disorder, PTLD.
Okay. Now I tell you that the patient is also running fever, high grade fever, frequent high grade fever.
Then lymphoma can also be a possibility.
That was a possibility. What is the other possibility? Are there more possibilities? Yes, there are more possibilities, though they are obviously less common, but they are still possible. What else can this patient have? Can he have something else also?
Pyelonephritis.
No. With regards to the stomach itself.
Graft versus host disease.
And that can also be there. Patient can have very common with these patients. They can have CMV related gastritis. CMV related bowel infection is also very, very common in post transplant scenarios. So that is another differential, and even CMV related gastritis will cause gastric wall thickening. And there can be small nodes even with that. The reactive nodes can come up even with that. So CMV is another differential for gastritis in such cases. CMV can also give this kind of picture. Okay. So you must have read the theory about the diagnosis already, I'm sure. The diagnosis is correct. You must have read the theory as well.
Yes, sir.
So can you tell me the etiology? What is the most common etiology?
Immunosuppression.
Immunosuppression and
EBV associated infection.
yes, EBV associated infection and even CMV, concomitant CMV infection, both can are risk factors for this post-transplant lymphoproliferative disorder. And the rest of the what other differential diagnosis will you keep?
After lymphoma, like gastric adenocarcinoma.
So why do you say that this is lymphoma and not gastric adenocarcinoma? Is
Gastric
there
adenocarcinoma is more of heterogeneous, and there will be perilesional fat standing will be there,
yes?
and it can cause obstructive symptoms. It may lead to upstream dilatation.
Yeah.
The lymph nodes are more of heterogeneous.
Is there anything with regards to the distribution of the nodes?
Regional lymphadenopathy is more common in adenocarcinoma.
And in lymphoma?
And in lymphoma, below renal hilum also lymph nodes can involve.
So that is a differential. And another lesion that can have a similar picture besides lymphoma and adenocarcinoma, anything else that can have a similar picture? No, though it is not. This is not the classical picture, but that can be a third differential.
GIST.
Yes, so GIST also will cause, because it is again having some mucosal infiltration, just like lymphoma. So GIST can all, but what will be the classical the clinching finding for a GIST?
It is more often exophytic and heterogeneous.
What else?
And usually no lymphadenopathy.
Yes.
Calcification is very rare in GIST.
What else?
Infiltration is more common.
What else? cysts also tend to ulcerate. The
Yes.
typical ulceration, you can see a puddle of contrast going into the lesion itself, into the wall of the lesion, burrowing deep in. That is very typically seen in just, you will see a lot of spotters also in the exam, where that will be helping you clinch that yes, this is a cyst. That is basically day-to-day experience with which I can tell you it is a cyst.
Yes, sir.
Okay, and how will you confirm the diagnosis in
Usually by biopsy,
what
endoscopic biopsy.
endoscopic biopsy? So that should be your plan. Ultimately, an endoscopy is required to distinguish whether it is a chronic inflammation or it is a malignancy. What are the likelihood that you will pick up a lymphoma versus a carcinoma, which is easier to diagnose?
Carcinoma is easier to diagnose in endoscopy.
Definitely. Why?
So it is more of mucosal ulceration, mucosal pathology will be more common, adeno. But in case of lymphoma, there will be submucosal infiltration will be more. Mucosa can be normal initial stages.
So, what if your initial biopsy is negative and you want another less invasive modality? What else can be of use? It is now available in most of the hospitals. In good hospitals, it is available. That modality is available.
PET CT.
PET CT.
No. PET CT not an endoluminal modality. I'm talking of an endoluminal modality only. PET CT, though, then
We have to go through endoscopic ultrasound guidance, then biopsy.
yeah, that is another way. PET is another third method. But for PET, what will you do with PET? Actually, you can do a lot with PET also. But what will you do after a PET? Now that you have raised the question.
To look for active lesions as
Yeah.
well as metastasis.
Hey, after you've seen a PET, you have found the active area. What will you do next? In case you've not been able to, you don't have endoscopic ultrasound. This thing has failed. Initial endoscopic biopsy has failed. What will be the next thing that you can attempt? I'm not saying you should attempt, but you can attempt in a very big, large, predominantly exophatic lesion.
You can go for ultrasound guided biopsy if possible.
Yeah, you should, rather than ultrasound, preferably you should go for a CT guided biopsy. Reason being, in ultrasound you cannot pinpoint the FDG avid area,
Yes, sir.
but in CT you can almost keep your PET CT side by side and you can target the area which is active. This is again based on experience, done it quite a few number of times, so I can tell you. So you are sure that you are hitting the area which is avid. In ultrasound, because those are two different imaging modalities, you cannot be that certain, you cannot be that objective. With CT, you will be objective.
Okay, sir.
You can keep ultrasound side by side on the table, use your ultrasound for the multiple number of passes that you are doing, but do it in the CT suite so that you are more objective. This is again based on day-to-day experience. Okay, so we'll come back to the first case. Regarding the first case, how can you say that this is sigmoid colon? I say this is rectum. How can you be sure that this is sigmoid? It is not rectum. Is there a particular landmark?
Usually, sigmoid colon will start after S1 vertebral body, and as associate and also sigmoid mesentery will help out.
Yes. What else?
And that anatomically, then
You come back to the images. You come back to the images that will help you. Go to the axial sections. Yes.
yes, sir.
Go down. Go down. Go down. Go down. Follow the rectum up.
Sigmoid takeoff.
Take
Yes.
off.
That is sigmoid takeoff. How will you identify it? See, this is the
Uh,
takeoff.
After that, it starts going anteriorly.
Yeah, when it suddenly takes a curve and moves in anteriorly, that is the area of sigmoid takeoff. So that is the anatomical landmark. And why do I need to distinguish that this is the sigmoid and this is the rectum? Is there any importance for the surgeon? Does it change the treatment?
Yes, it does.
How? No, that may not be relevant immediately to a radiology resident, but once you are actually sitting in the tumor boards, discussing with the surgeons, listening back to them, then you need to be sure.
Because in case of CA rectum, the chance of peritoneal involvement is less, whereas in case of CA sigmoid, the peritoneal involvement is more likely.
Not just
And-
that, actually, peritoneal involvement is one thing, because with peritoneal involvement, I'll come to that also. That will change the prognosis. Secondly, the treatment is different in such a large rectal mass. You usually cannot do a surgery. You will have to go for a neoadjuvant therapy. While in case of a such a large sigmoid, usually still there is not much role of chemotherapy. They still have to operate. This case is already localized perforation. They have to operate. They have to do a stoma.
Okay, sir.
So treatment differs. In sigmoid, there is less role of chemotherapy vis-a-vis rectum. Acha, what if there is peritoneal dissemination? How will you pick up peritoneal dissemination in this case? What areas will you look at?
Paracolic gutters, peritoneal thickening,
Yeah,
sigmoid, serosal deposits.
yeah. So what will be the favored sites for those serosal deposits?
Along
Peritoneal
the,
recess.
along the sigmoid mesentery,
Yeah,
then mesocolon of
which side will you find the deposits more, the left or the right?
right.
Right side.
Why?
Because the movement of peritoneal fluid will be like that, right side will be more dependent.
Yeah, correct. And what well, suppose you find did you see the you could see the liver. Suppose you find lesions in the liver. What will be the typical characteristic of those liver lesions?
In case of adenocarcinoma,
Yeah.
hypoenhancing lesions
In which phase?
in portal venous phase.
Portal venous phase. You will find hypoenhancing lesions. Hypoenhancing with respect to what?
With respect to liver parenchyma.
The surrounding liver parenchyma, yes. They will be hypoenhancing. And uh, what else can help you? Basically, you have already operated the patient. You already operated the patient. What will be the lab criteria that you will use, that you will need to keep on following?
Carcinoembryonic antigen, tumor marker.
CA is to be followed, and why are you following CA? What if there is a rise in CA? What will you do?
Rise in CA may indicate a recurrent lesion.
How will you look for the recurrence?
PET.
PET imaging.
Cross-sectional imaging, including PET CT.
Will you always need to jump to a PET CT? You know that there is a difference in the cost. There is more radiation.
In the immediate post-op, PET CT may be better.
No. PET CT will not help you. Even if there is any inflammation, it will definitely pick up. So PET will not help you in the immediate post-op period. I am saying there is a after 6 months there is been a rise in the CEA. What will you do?
Cross-sectional imaging, CCT again.
CT again. And when will you resort to a PET? Suppose there is a financial issue, you don't want to jump to a PET CT, but still you might need to do a PET CT
when there is a doubt, equivocal cases.
Yeah, in equivocal case, then you need to resort to a PET CT, because then the information from the PET part that will help you that this area is active. Then definitely you will need to think of it being a metastasis. Acha, where all can IR come in such a case? In what all scenarios will you need to resort to an intervention?
In case of active bleeding.
Yes. What else?
Or if there is a large mass where you can embolize.
Well, usually not required, but maybe yes. What else?
Then targeted chemotherapy.
What kind of targeted chemotherapy?
In case of solitary liver mets.
Yes. Actually, in a solitary liver met, it is easy. What is the best treatment for a solitary liver metastasis?
Resection.
What?
Surgical resection.
Yeah, surgical resection. If surgical resection is not possible, then what?
RFA.
RFA or what?
TACE.
Or what? You will not say RFA, you will say thermal ablation actually. Because because nowadays thermal ablation is not just RFA. What else? What else is there with thermal ablation? Is there any other commonly available thermal ablation now? At least in the metropolitan cities, in the bigger cities, now the guys are traveling all across the length and breadth of the country.
Laser.
What else besides cryo? Cryo is not that easily available. Somebody has mentioned cryo in the group. And why will you choose among the two modalities of thermal ablation? Which will you choose when? If you have to limit the cost? Yes. It is microwave. Microwave is another modality which can do the ablation. But when will you choose microwave and when will you choose RFA if cost is an issue? Because microwave definitely costs much more than RFA, at least in the day-to-day practice. Any idea about microwave?
No, sir.
Microwave does the same job as RFA. Actually, it will again burn out that area, but RFA has a particular problem that there is a heat sink. If the lesion is close to the vessels and if the lesion is large, your ablation zone is not going to be that effective, because if it is close to a vessel, the heat that your needle generates, it will all be getting drained into the vessel and your lesion will remain untreated.
Okay.
Unlike that, in microwave, heat sink doesn't have any role. So if your lesion is hugging the portal vein, still you can do a microwave, unlike RFA. The ablation zone with microwave is going to be larger compared to RFA, so the therapy is going to be more effective. So for larger lesions, you will again resort to RFA, microwave compared to RFA. So now microwave is easily available, at least in all the metropolitans. I'm sure it is there. Microwave also has to be kept in mind as one of the treatment options. Well, what else? I think most of the things we have already discussed. Acha, will you look at when you're looking at the CT? Will you look at any other risk factors? Will you try to identify other risk factors?
Syndromic.
What so that and then the direct question is, what are the risk factors for colorectal malignancy?
Polyposis. Familial adenomatous polyposis.
What else?
Non-polyp
Syndromic associations.
HNPCC,
Yes.
CA breast.
So how will you for example, you have a boy who has been diagnosed with one of the polyposis syndromes. How will you basically screen him?
Colonoscopy.
He doesn't want a colonoscopy. What else?
Virtual colonoscopy.
Virtual CT colonoscopy.
You can do either a virtual colonoscopy or what else?
Barium.
Barium.
Barium also you can do in CT itself. Barium is now gradually getting outdated. Practically, it is. You can also do a water enema. With water enema, you can give the patient enema. Good pressure. You can give the patient enema, and that will distend your colon. Then you give contrast. That also works well. Most of the polypoidal lesions you can identify even with a water enema, and do a good decent quality screening. Acha, when will you start the screening? When will you start the screening in a given case? Is there a recommendation? Hello?
Yes, sir, we are listening.
The recommendation is that screening program starts at the age of 40, or if you already have a family history, then 10 years less than the age of affection of the youngest person. This is true for all the malignancies, not just for colon cancer, even CA breast. If there is a family history, then supposedly the lady got affected at the age of 50, then the next generation has to be started screening at 40. So 10 years gap to pick up the disease early.
Okay.
So that is the general rule followed for all malignancies. For example, if you are suggesting mammography in a case of BRCA positive so that has to be again started 10 years earlier. If the mother was CA breast or CA ovary, then you start looking for the disease 10 years earlier in the daughter, so that you are able to pick it up well in time, that the early diagnosis has a benefit.
Okay.
I think we've gone in decent detail already. Anish, can we close down the session?
Sir, what was the polypoid from the bladder?
That can again be two things, but given that this is already a case of CA sigmoid with contiguous involvement, most likely it is again contiguous this disease itself. Other thing, definitely it can also be a simultaneous TCC. That may also be a possibility, but to me it looks more like contiguous involvement from CA sigmoid only.
Okay, sir.
Done right, Anuj?
Yeah, I think we have
Okay, Anuj.
done quite well actually. They've spoken most of the findings.
Yes, voice is breaking.
Yeah.
Yeah, Dr. Anuj. I must say it was very much engaging discussion. Govind ma'am, you want to say?
Yeah, it was a wonderful discussion. The two cases. I think one case was ours and the second case was yours. I think so. Isn't it, Anish?
Yes.
Yes, ma'am.
Yeah. So it was a wonderful discussion and each point was covered by the discussion. So thank you so much, Dr. Anuj, for being with us for this 1 hour. The residents also had got an excellent workup of the cases also. Thank you so much, Dr. Anuj.
Thank you, Anuj, for accepting my request. And in spite of your busy schedule, you agreed to be part of IRIA Kerala. Thank you, Anuj. Thanks again.
Dr. Venu, anything? Dr. Venu?
Yeah. So actually, I was just hearing, and the way Dr. Anuj was asking, no, it is just like in the exam. So the questions and all. Okay. So the
Yes, sir.
candidates are becoming a little panic in answering.
Yeah.
So it's wonderful. You are a good
Yes.
examiner. Okay, and Dr. Anuj. No,
Thank
one thing regarding the first case, no. First case actually it's a beautiful case, multiple findings, multiple small findings. And that case, the lesion in the vertebral body, you know. So there is a defect in the upper end plate of one vertebral body. That could be a small node. But even I was thinking of whether this could be a defect, wedge-shaped defect in the end plate. In the context of a small GB calculus, no. This can be sickle cell anemia. So I think we have to consider that also, that point also. Sickle cell anemia can produce wedge-shaped defect in the end plate. So GB calculus can also be associated because of the hemolysis, increased hemolysis, GB calculus can also develop. And that's all. Otherwise, very good. Very nice. Questions were asked.
Yes.
Okay. Thank you very much.
Yes, there was a bit of experience from your
Definitely.
intervention side also. It was even though it's not very commonly practiced here, it is being done. Still, it was a good discussion point for our PGs.
Once the kids step out into the environment, this is how we face the things on a day-to-day basis. The next question is, what will you do? Will you do something or will you leave? So we have to be
Sure,
prepared.
Yes.
Yeah. Thank you. Yeah, thank you so much.
Yeah, okay. Thank you, Anuj, once again. Now I thank our IRIA State President, Dr. Gaumudi ma'am, and our State Academic Coordinator, Venu sir, and State Academic Chairman, Dr. Ramesh Anay sir, for organizing this session. And a special thanks to our platform that is JournoMed, MedPiper, especially Soumya, for giving us this platform. I also thank the residents and also the consultants who are viewing our sessions. Thank you all once again.